Hello everyone, and thank you for joining today's webinar. My name is Lynn Labarda and I'm with iMark Billing, and we specialize in billing and coding for the home health and hospice industry. And our job is to handle the billing and the coding for agencies all over the country so you all can focus on patient care and growing your business. So today I wanted to talk about PDGM. So all Medicare certified home health agencies are on alert. We have PDGM around the corner, practically here, effective January 1, 2020. And I wanted to share some basic information on what you need to know now for PDGM. Really break it down, make it as simple as possible, and show you what are the steps that you need to do at your agency now so you can have the ultimate payment results come January 1, 2020. All right, well, thank you so much. Let's get right into it.
All right, so here we are, and PDGM is here. So we want to know if you're leaving money on the table, and that's what we're going to go over today. We're going to just do it very simple, quick, and easy understanding of PDGM and how you can optimize your revenue. So first of all, the PDGM changes. The most basic changes. There are no more therapy thresholds. So that is obviously a very important point of all of this, that you're not going to be reimbursed by the number of therapies that you're doing anymore. The episode timing definition has changed, early versus late, and we'll get into that. Your admission source definitions have also changed. We're now looking at a community referral versus an institutional referral, and we'll get into those as well. Clinical groupings, there's 12 clinical groupings. They're all based on your primary diagnosis. Your functional levels are going to be very important towards your reimbursement as well, and they come from your OASIS. Your comorbidities are your secondary diagnoses that could increase your payments. And that's why coding is so important under PDGM. Your Lupa threshold is a very big change. Instead of what we have now, it is changing, well, what we had under PPS really. It's changing under PDGM with a 2 to 6 range instead of just a fixed 5 visits. So we'll get into that. RAP payments, of course, are going to continue for agencies that have been in business and have had their Medicare certification before 2019. But any new agency that received their Medicare certification on 2019 or after will not receive any RAP payments. And then, of course, our unit of payment has changed from a 60-day episode payment to a 30-day payment. All right, so what has stayed the same is very important under PDGM, and this is one of the sources of confusion for agencies. So we already mentioned that RAP payments will continue for agencies that were Medicare certified before 2019. The RAP payment, though, has changed. The RAP payment is 20%. So that means that once you bill the final, you'll get paid the remaining 80%. And of course, for agencies that were certified on or after 2019, they will not get a RAP payment altogether. Their payment will come in full upon final. Now, your 60-day certification period has not changed, okay? Your assessments are still done within 5 days. As far as the start of care needs to be locked and completed within 5 days. And if you're going to do a recertification, it needs to be done within the last 5 days of the 60-day episode. So that has not changed. Your plan of care corresponds to the 60-day certification. That has not changed either. Your OASIS timeframes remain the same. You've got to transmit those OASIS within 30 days. Your COPs have not changed. And all of your orders need to be signed before that final is billed. So that has not changed. So let's talk about that 30-day unit of payment. So now, instead of billing a RAP and a final for every 60 days, we're going to be billing a RAP and a final for every 30 days that the patient's on service with you. Okay? So that is a very big difference. And this is the source of some confusion for agencies because our payment workflow has changed, but our certification workflow has not. And we'll get into that a little bit more in the upcoming slides. Now, the average 30-day payment is around $1,864.03. Now, that is a national average, okay? So again, it means that you're paid every 30 days. It could be a lot more than $1,800 or it could be less. So far, early in this year, we have been seeing some wound cares paying out at $3,500, $3,200. We've been seeing a lot of different payment ranges for the 30 days. So again, remember that this does not affect your certification period. All of your documentation still covers a 60-day episode. So let's talk about the payment workflow, which has changed. So now we've got 2 30-day periods within one 60-day certification period. Okay, so we're going to be billing a wrap and a final for each 30 days the patient's on service with us. So when a patient's admitted, there's a 60-day episode that's created. So that stays the same, okay? And that's going to be called your certification episode, your episode. Now, billing is done every 30 days that the patient's on service, and that we're going to call our payment period, okay? We're going to bill once at the beginning of the payment period, and that's called a wrap. So even if you're an agency certified on or after 2019, we still have to bill a wrap, okay? Now, we're going to bill once at the end of the 30 days or earlier if the services are over, and that's going to be called your final or your EOE, which stands for end of episode. So 30-day period is basically going to equal day 1 through 30 of the current 60-day episode. Day 1 is the current 60-day episodes from date. And then, of course, the second period is day 31 and above. So essentially, we're going to be billing monthly, okay? So your softwares, when you enter the 60-day, they're going to give you a 60-day episode, but then they are going to break down the payment to the 30-day payment period, and they're going to give you your payment amount based on the 30 days. That's actually been a source of confusion because when agencies are entering their patient information and they're getting a payment amount, they're getting a little bit confused and thinking that that payment amount is for the full 60 days, but it's not. It's for the 30-day period. So like we said before, your certification period or your certification episode hasn't changed. You've got 60-day timing for your certification period. Your plan of care still corresponds to the 60-day certification. Your startup care oasis covers the 60-day episode. And of course, if you can still do a recert like before. You've got to do it within the last 5 days of the first episode. And that recertification is going to create another 60-day episode so you can continue seeing the patient. So here's a really good graphic that shows you the 60-day certification period versus the 30-day billing period. So as you can see on top, you've got your 60-day certification period. So your orders are going to cover your 60 days. You can see that you've got your start of care oasis, and then you have a discharge oasis or a recert oasis. And of course, you can have a discharge done anytime in this timeline, okay? Now, your 30-day billing period is a different story. Now we're talking about actually billing the billing for the episode. So it is broken up into 2 30-day periods, as you can see here. So let's kind of follow this example a bit. So let's follow day 1. So we've got day 1 of the 30-day period. So we're expecting that maybe around day 6 to 10, you're going to be billing the first wrap, okay? Because remember that the criteria for the wrap has not changed. We have to have the first billable visit marked as completed in the software. Your oasis has to be completed, locked, we recommend that you transmit the OASIS already to CMS. And of course, your plan of care has to be established. So all of that criteria has not changed in order for you to bill the first wrap. So because of that, we're expecting that you may be billing the first wrap around day 6 to 10. So here you go, you're gonna continue seeing the patient. Let's just assume that this example is for a patient that you're gonna be seeing every, let's just say every day for 60 days as an example, okay? So here you go, you're gonna continue seeing the patient, and now day 30 comes. On day 30, or a little bit after day 30, you're gonna have to make two decisions. In other words, you have to think about sending the first final and sending the second wrap for billing, okay? So in order to be able to send the first final, all of the visits have to be marked as completed, and all of your orders need to be signed just like it has always been. So by the time day 30 comes, chances are and hopefully you do have all of your orders signed and your visits completed, but let's just say that you don't. That means that on day 30, you're probably not gonna be able to bill the first final. So here we go, we continue, okay, after day 30, so day 31, 32. So by then, we're hoping that your second wrap, the criteria has been met, okay, in order to be able to bill that second wrap. So in reality, you're probably gonna be billing the second wrap before you even bill the first final, because the only criteria in order to bill the second wrap is it's the same as the first wrap. The first billable visit has to be marked as completed, the OASIS has to be completed, and the plan of care has to be sent to the physician. By then, the only thing you're probably gonna have to worry about is if the first billable visit has been completed. So let's say that you had a first billable visit for that second 30 days set up on day 31. Okay, so if on day 31, let's say you had a nurse going out to see the patient, then as soon as that visit has been completed on day 31, you're ready to send the second wrap. So we're hoping you're gonna be sending the second wrap anywhere between 6 to 10 days after the 31 days, hopefully even sooner than that, okay? So here you go, you continue seeing the patient, and the second final, we're hoping you're gonna be able to bill anywhere between day 31 to 39, because all of the orders have to be completed and signed in order for you to bill the first final. So here you go, you continue seeing the patient during that second 30-day period, and as soon as those services are over or you hit the 60-day mark, you're gonna be able to bill the second final, as long as, again, the criteria has been met, which is the orders are all signed, and of course the visits have to be marked as completed. So this is a really good graphical representation of what your billing cycle is gonna look like. Because again, you know, I wanted to highlight how your certification period hasn't changed, but your billing cycle has changed. So here's an example of your cash flow. So your cash flow now under PDGM is gonna be slower. And this has actually been surprising for some agencies. So here's an example. Let's just assume that this is a new patient and you're seeing them for 60 days. Before, under PPS, let's say that the full claim was gonna pay you $2,500, okay? So before, you would bill a wrap and you'd get $1,500, and you bill a final at the end of the episode and you'd get $1,000, okay? Very simple. Under PDGM, Medicare is piecemealing our money. They're breaking it up into small chunks. So our cash flow is going to be slower. So let's just say the same patient under PDGM that's also worth $2,500, we're going to bill our first wrap and you're going to get $300, okay? And then we've got to bill that first final for you to get the next $1,200. Then you've got to bill a second wrap to get another $300 and a second final to get the remaining money, the last $1,200. So as you can see, it's very clear to see here that the monies are going to be given to you a lot slower. So this is a big concern for agencies because they relied on that first wrap money to cover their payroll. So what this means is there's an acceleration of billing really that we've got to do. We've got to make sure that we can bill that first final as soon as possible, as soon as 30 days, 31 days in order to get that remaining monies. So that is really a concern. A lot of agencies we've spoken to recently, because they're looking at those wrap monies and they're thinking that there's a problem. But no, the wrap is 20%. So that is why the wrap monies are a lot less, and we've got to hurry up to be able to send those finals. So again, no more therapy thresholds. Obviously under PPS, the more therapy essentially you did, the more money you made. That was kind of the idea. So under PDGM, we're not paid per threshold, by a threshold or per visit anymore. So the industry has stated that 8 therapy visits during a 30-day period is considered approximately a break-even point from a financial perspective, of course. So, 8 therapy visits during that 30-day period is considered a lot. Now, obviously, agencies need to perform whatever therapy visits the patient needs in order to rehab enough to get to the front door, to get into a car, to end up going to outpatient therapy. But just keep in mind that we are not tied to any thresholds for reimbursement anymore, so you do have to analyze the cases from a financial perspective as well, but at the same time providing the appropriate level of therapy. So there's a misconception that agencies think that they're not going to get paid at all for patients that are therapy only, and that is not the case. You still are going to be paid. It's just the formula, the reimbursement methodology has changed. So a lot of agencies are considering outpatient therapy or therapy part B under your home health. That is acceptable. You can bill Part B Medicare under your home health license. That's something that you can speak to your billers about, and they can fill you in on how that process works. So let's talk a little bit about the drivers of reimbursement under PDGM, and basically there's 5 drivers that we're going to discuss today. So this is going to be really important for you to understand how Medicare is reimbursing claims under PDGM and how you can optimize your revenue. So your admission sourcing, your timing, those are 2 of our drivers for revenue under PDGM. Your clinical groupings, your functional impairment levels, and your comorbidities are the rest of them. And that's going to comprise how Medicare is going to reimburse you under PDGM. So let's talk about each one of those. So episode timing, your early versus late, there's not much you can do about this. You're going to pull up your Medicare eligibilities, and that's where you're going to determine where if the patient is in early episode or late. So a patient, basically the first 30-day period in a sequence of home health periods is considered early. And a late period are the second or later 30-day period in a sequence of home health periods. Okay, so you'll know this by pulling the Medicare eligibility. Now, if there is a gap of 60 days or more between the end of one 30-day period and the start of another, then it does reset and it is considered early again. So obviously, if you get a patient that is early, who has maybe not had home health before or has had a big gap of 60 days or more, then they're considered early and you are going to get a higher payment. If it's considered late, then the payment is going to be slightly lower. But again, there's not much you can do about this. It is what it is, but you'll know by looking at that eligibility. Next driver of your reimbursement is your admission source. So here's where you can potentially do something by marketing more towards institutional providers, which are going to pay out more. So you've got community or institutional as an admission source. Your community admission source is your physician referrals. Medicare thinks that you're going to have lower resource use for these type of patients, so that's why they're going to be giving you a lower payment. Okay, Medicare's thinking these patients aren't as sick. Now, an institutional referral is that the HHA starter care must be within 14 days of an inpatient care acute hospital, a skilled nursing facility, an inpatient rehab facility, or an inpatient psych facility. Also a long-term care hospital discharge. So if that's the case, then that period, 30-day period, is considered institutional and it's going to be paid more. Why? Because Medicare feels these patients are sicker and you're going to have more resource use. Now, keep in mind though that if the patient goes to an emergency room or doesn't get admitted or has any kind of observation days, that's not considered institutional referral. They actually have to have been admitted into an institution in order for you to get that credit. So an institutional referral is going to pay more. It's going to pay about 40% more than a community referral. So you can basically think that for every one institutional referral that you get, you're going to need 2 community referrals to offset. It's approximately a $600 to $800 difference, $600 to $800 more for an institutional referral. So here's an opportunity where you can change your marketing efforts a bit and focus more on these institutional providers so you can increase your revenue for the agency. So if a RAP, and this is something to know about the admission source, if a RAP is submitted and paid with a community admission, and then an acute or post-acute Medicare claim was submitted for that patient before the final is billed, then the RAP would not be adjusted. Only the final will be adjusted to reflect that it's an institutional admission, okay? So only the finals, the RAPs don't change, just the finals are adjusted to reflect that the patient was admitted to a hospital or a post-acute center, and you would get a higher payment. So another important point to understand about the admission source and the timing and the late episodes. So a late 30-day period, that's always considered community, a community admission, unless there was an acute hospitalization within the prior 14 days of a late home health 30-day period. And if that's the case, then the HHAs have the option of discharging the patient and readmitting them, but you don't have to. If the patient did go into a hospital setting, your second 30-day period would be classified as institutional. Now, that is very different from a post-acute stay. So a post-acute stay in the 14 days prior to a late home health 30-day period would not be classified as an institutional admission unless the patient has discharge, unless you have discharged them and readmitted them as a new patient. So if the patient goes into a hospital, you don't necessarily you don't have to discharge and readmit to get the institutional credit. But if the patient goes into another type of facility, like a skilled nursing facility, inpatient rehab, any other post-acute stay, then you do need to discharge in order to get that institutional credit for the next 30 days, okay? So if a patient goes into a second or more payment period, which is a late period, and they go into a post-acute facility, it is recommended that you discharge the patient. We just talked about that. Why? Because your next payment period will be categorized as institutional, as long as, of course, your admit date is within the last 14 days of the discharge from the post-acute setting, and that means you're going to get 40% more. So it is recommended to do that if the patient goes into a post-acute care facility. So let's talk a little bit about your clinical groupings and your functional impairment levels. You've got 12 subgroups based on your primary diagnosis. There's a list of 42,000 and a little more PDGM diagnosis codes that are considered appropriate for your primary diagnosis. Now, your software, when you enter your primary diagnosis, should tell you if that's an acceptable PDGM code. If it does not, you can go onto our website. In our website, on the bottom left of the slide, you can see our website address. You can click on the PDGM tools and you will find a lookup tool for your primary diagnosis so you can see if it's appropriate. Now, coding is more important than ever under PDGM, because if you do not get the right primary diagnosis, your claim is going to be returned to provider and is not going to be processed. So it's going to be very important to get the primary diagnosis right. Your wound cares and your complex nursing cases are going to be your highest paying cases under PDGM. So instead of before under PPS that agencies wanted to get therapy because those were the highest paying cases, now it's opposite. Okay, now it's going to be your wound cares and your complex nursing cases that are going to pay out more. which is very different because before, under PPS, some agencies would shy away from wound cares because they were very costly. So they're still going to be costly in the sense that you still have to provide all of the supplies, but they are going to be paid at a higher rate. So that's good. Your functional impairment levels, there's 3 groups. So you can have either a low score, medium, or high. And this is all coming just from your OASIS, okay? So obviously the worse the patient is, the more points you're gonna get from a functional standpoint, and the more money you're going to receive, okay? So that is the functional impairment levels are the only section on the OASIS that are gonna impact your reimbursement. So your comorbidity or your secondary diagnosis codes, those are also critical under PDGM. We've got 24 slots in your software on the claim that where you're going to have an opportunity to put any secondary diagnoses that could potentially increase your payment. In fact, you could receive a 20% more for a particular 30-day period if you've got the appropriate secondary diagnoses that can affect the plan of care. So again, coding is very important. You need to really make sure that whoever's doing your coding is trained for coding under PDGM, or you may consider outsourcing that to a company like ours. Same thing as billing. You know, the billing process has changed completely. So you've got to make sure that your billers understand the new payment methodologies under PDGM. Otherwise, consider potentially giving that off to a company that does understand. So your new Lupa thresholds are a big deal under PDGM. The Lupa thresholds are now a range, anywhere between 2 to 6 per 30-day period. That is very different from what we were used to before. So now, in order for an agency to know if that particular 30-day period is going to be a Lupa, you need to know your HIPS code, which comes from your OASIS. So you're going to, either your software is going to tell you what the 30-day Lupa period is, because it can also change for every 30 days, okay? If the software does not tell you, you can also go into our website under the Lupa lookup tool, and you can just plug in the HIPS code, and it will tell you what the Lupa threshold is for that particular 30-day period. So note, and you need to be very careful, that when you're going into a second 30-day period, you really need to know what that Lupa threshold is. So hopefully, if it's clinically appropriate, of course, you can meet that Lupa threshold. So wrap and final billing guidelines, we did talk about this earlier, those have not changed. To bill a wrap, in order for you've got to meet that criteria. The OASIS assessment needs to be completed, locked. We recommend that you export it already. The plan of care has to be established and sent to the physician. The first billable visit has to be delivered and documented in your home care software. So this goes even for your second 30-day wrap that you're going to be billing, that second wrap, that first billable visit needs to be marked as completed in the software as well. In order to bill a final, all of your orders need to be signed, your face-to-face if it's appropriate, if it's applicable for the first patient, for a new patient, needs to be done. And of course, all of the visits need to be completed as well. So auto wrap cancellations, that's been a big question. Those are going to continue. So auto cancellation is going to happen. And your payment recoupment, when the final is not sent timely, does remain the same. Now, obviously, if you are an agency that doesn't get paid on a wrap, you're technically not going to get any money taken back, but your wrap is going to be canceled. And you do have to resubmit that wrap in order to get that final paid. So finals, so the new timeline is that finals must be submitted within 60 days from the end date of a 30-day payment period. So that is slightly faster than what we had before. So 60 days from the date the wrap is paid as well, whichever is greater. So that is something to consider. We're still going to get those wrap takebacks if we don't get those finals billed timely. So for 60-day episodes that begin on or before December 31, 2019, they can end on or after January 1. That doesn't matter. It's about the beginning date. of the episode, those will be under the 60-day episode payment amount. So those will still fall under the PPS rate. Okay, so this has also been a bit confusing for agencies because they think that the end date has something to do with PDGM. No, if your episode starts in 2019, then it's going to be paid under PPS. Now, for HHA's periods of care that begin on or after January 1, 2020, the unit of payment will be the 30-day payment period. And of course, any recert OASIS that are on or after December 27th need to be on a D1 OASIS and have the M0090 date of assessment of January 1, 2020. It makes sense because that means that the new episode is going to be starting on or after January 1, 2020. So that's why you need to have a D1 OASIS and your MO90 has to be January 1, 2020. Okay, but obviously if you're doing a recert and the next episode, the new episode doesn't start on 2020, then you're not going to do this. You're going to do the regular OASIS and you're not going to put your MO90 date as January 1, 2020. All right, so I think for any questions, here's a slide that has my address, my email, the website, my phone number. If you've got any questions on this, please feel free to shoot me an email, give me a call. I would be more than happy to answer this. This was a quick 30-minute overview of PDGM and how you can maximize your revenue. Again, please feel free to ask me any questions. I'd be more than happy to go over those with you. Thank you and good luck with the PDGM process.